there's another abstract that we're also very excited about, and that is the nature of deletions in 11q. And that's something that previous studies reflected on this, but published a paper a few years back where we noted that patients with deletion 11q, which is commonly called an adverse genetic marker, they may do less well than patients who do not have that marker. That's particularly true with chemotherapy. They may respond to chemotherapy, but the response is short-lived. And what was striking to me is that patients treated on the RESONATE-2 study, this was a study where patients received Ibrutinib as frontline therapy, and that was compared against patients who received Chlorambucil as therapy. The patients with Ibrutinib who had deletion 11q did amazingly well. And so we looked at other trials of Ibrutinib in frontline patients, and we found that patients with 11q minus did very well. And so they actually did better than patients without deletion 11q. So here we go again. An adverse risk factor is turned on its head and may provide hope that if you had this, it's now a good feature. Now, that wasn't the case in the early trials with Ibrutinib, namely the RESONATE study. And that study studied patients who had prior therapy. In that case, the patients who had deletion 11q actually did less well than patients who did not have 11q. So what's going on here? In one case, it's a good risk factor. In another case, it's not a good risk factor. Well, the difference is primarily in the lines of therapy. So in the RESONATE study, patients had prior lines of therapy, and it was clear from the outcome analysis that if you had more rounds of previous therapy and then got treated with Ibrutinib, your response was less robust than if you had fewer lines of therapy. And that was also carried forth in patients who received Ibrutinib as frontline. They even respond better. So the idea of using chemotherapy and reserving therapy such as Ibrutinib in reserve after patients fail chemotherapy has to be reconsidered, because you shouldn't do this. Patients treated with chemotherapy may be adversely affected if they have certain genetic factors such as deletion 11q in particular. So what we did was we analyzed this in a number of patients. We have assembled a number of cases where we have patients with deletion 11q, and some patients of these were treated with Ibrutinib as a drug. We had patients also receiving chemoimmunotherapy or chemotherapy who had deletion 11q, and we had access to pre-treatment leukemic cell samples as well as post-treatment leukemic cell samples. And what we did was to look at the genetic changes that might occur with therapy. And it was striking in that with the chemotherapy, patients of deletion 11q acquired more cytogenetic changes or genomic instability. There's something about deletion 11q that makes that disease more susceptible to change with chemotherapy. And we don't see that same change happening in patients who were treated with Ibrutinib. So newer lines of therapy may be putting patients at less risk for subsequent genetic changes. And this is highly important as we consider how do we dose our patients? What sort of factors do we need to know about our patients before we start therapy? And we have to take into consideration that what we do in terms of treatment can affect the outcome to subsequent treatment if it's required. And so this is another story which I think is very exciting because it goes along the line of what I said earlier about never telling a patient they have bad risk disease, but we have to practice good medicine. We should take patients and ignore the consequence of therapies that will make the outcome less robust to subsequent therapies, including these newer targeted therapies. Very important considerations to have.